Imagine a 28-year-old patient sitting across from you in your consultation room. And, I mean, she is in blinding, debilitating pelvic pain.
Right. The kind of pain that just entirely incapacitates you.
Exactly. And your imaging reveals this massive, like a 3-centimeter endometriotic nodule heavily infiltrating her rectum. And above all else, she just desperately wants a baby.
Which creates a really agonizing clinical dilemma.
It really does. Because for years, the standard, universally accepted medical guidelines have told you, the physician, exactly what to do with this patient. You bypass the anatomy, leave the nodule right where it is, and send her straight to the IVF clinic.
Right. The goal being to save time and protect her ovaries.
Right. But what if the data showed that putting her through a grueling 4-hour, highly invasive bowel resection actually gets her pregnant significantly faster?
Yeah.
And entirely naturally.
Yeah, that completely flips the script.
It does. Today, we are looking at the data that is quite literally tearing up the old rule book.
It is a profound shift, really, in how we approach one of the most complex clinical scenarios in reproductive medicine. We're looking at a patient population where the pathology has completely distorted the normal pelvic architecture. And for decades, our response was essentially to, well, work around the rubble rather than clear it.
Yeah. Welcome to another deep dive. Today, we are speaking directly to you, the medical professionals, the pelvic surgeons, the gynecologists, and the reproductive endocrinologists who are navigating these exact, highly fraught clinical decisions every single day.
It's the front lines of fertility treatment.
Exactly. We are grounding our entire discussion today in a deeply disruptive study. It was published in Human Reproduction back in 2018. The paper is titled, High Postoperative Fertility Rate Following Surgical Management of Colorectal Endometriosis by lead author H.Roman and an extensive team of researchers.
And we should clarify, this isn't just a standalone study. It represents an extended follow-up of the landmark ENDORE trial. And we really must emphasize why this paper demands your attention. It targets a highly specific, incredibly symptomatic patient population with deep infiltrating endometriosis, or DIE of the rectum.
We're talking about patients who are simultaneously battling severe chronic pain and infertility, right?
Exactly. It's a brutal combination.
So our mission today is to provide you with a comprehensive, granular update on what has historically been a fiercely debated clinical question. When you have that young patient with severe colorectal DIE who desires pregnancy, what is your primary maneuver?
Do you risk the surgery, or do you go to ART?
Right. Do you send her to the OR for a complex, inherently risky clearance of the pelvis? Or do you lean on artificial reproductive technology like IVF as the first-line defense?
And to really understand the magnitude of what the Roman paper proposes, we have to look back at the historical context.
Let's do that. Let's look at the 2014 ESHRE guidelines, the European Society of Human Reproduction and Embryology. They were incredibly rigid on this, weren't they?
They were unequivocal. I mean, the 2014 ESHRE guidelines explicitly stated that there was no evidence supporting the surgical management of deep endometriosis prior to ART if the sole objective was to improve pregnancy rates.
Wait, no evidence at all? Or just a lack of, randomized controlled trials? Because those are two very different things in clinical practice.
That is the crucial distinction. It was a lack of high-quality, randomized controlled trials. So in the absence of head-to-head surgical data comparing operative outcomes directly against IVF, the guidelines defaulted to a posture of defensive medicine.
Right. Play it safe.
Exactly. The prevailing logic was that primary IVF shortens the time to conception, and perhaps most critically, it protects the ovarian reserve from potential iatrogenic damage during complex pelvic surgery.
Because you don't want to risk the ovaries if the ultimate goal is a live birth.
Precisely.
Okay, let's unpack this defensive posture. Because the Roman paper actively challenges this clinical dogma.
Okay.
They took a look at that no evidence claim from ESHRE and essentially decided to generate the missing evidence themselves.
They built the data set we were missing.
Yeah, but when we look at the ESHRE recommendation to just bypass the disease with IVF, we have to acknowledge a glaring clinical blind spot. IVF brilliantly addresses the biological mechanism of conception, the symptom of infertility, but it leaves the underlying pathology entirely untouched.
It does. It leaves behind this deeply infiltrating, highly innervated, actively bleeding colorectal nodule. What's fascinating here is when we push a patient toward IVF to protect her ovarian reserve, we are asking her to endure the agony of her disease through rounds of ovarian stimulation, pregnancy, and postpartum recovery.
Oh, yeah.
How do we balance the deep biological drive for a child with the immediate humanitarian need to relieve debilitating chronic pain?
It's a massive ethical and clinical question. And to really understand how H.Roman and his team attempted to answer that, we need to examine their methodology. We're moving out of the abstract debate and into the literal operating room at Rouen University Hospital in France.
Which served as the expert center for this extended follow-up. And the term expert center cannot be overstated here. The procedures we are about to discuss are not being performed in a standard community hospital setup.
You don't just walk into a local clinic for this. So let's look at the patient selection for the original ENDORE trial, because these were not, incidental findings of mild endometriosis during a routine laparoscopy.
Not at all. We are looking at extreme end-stage presentations of the disease.
The inclusion criteria were incredibly strict. Patients had to have deep endometriosis infiltrating the rectum up to 15 centimeters from the anal verge.
Yep.
The nodules had to measure more than 20 millimeters in length. They had to involve at least the muscular layer of the bowel wall in depth and could involve up to 50% of the rectal circumference.
To put that in anatomical perspective for the clinicians listening, a 20-millimeter nodule infiltrating the muscularis of the rectum is a massive fibrotic distortion. You are often looking at a completely frozen pelvis where the posterior cul-de-sac is obliterated. The anterior wall of the rectum is densely tethered to the posterior cervix and the upper vagina.
Basically, the normal anatomical planes are completely erased by this dense, woody fibrosis. It's like a structural roadblock in a complex transit system.
That's a great analogy.
They aren't just surface issues. They are fundamentally altering the pelvic anatomy. So the surgical arms had to be incredibly precise. The original ENDORE trial was an unblinded, one-to-one parallel arm randomized controlled trial.
Right. The patients were randomized into two distinct surgical pathways.
What were those?
They were randomized to either receive conservative surgery, which involved either shaving the nodule off the bowel or performing a full-thickness disc excision, or they were randomized to radical surgery.
And radical means?
Full segmental colorectal resection, literally cutting out the diseased segment of the bowel and re-anastomosing the healthy ends.
Okay, wow. And who was actually holding the instruments during these procedures? Because, the composition of the surgical team is a massive data point when we evaluate the reproducibility of this study.
It absolutely is.
You had one highly experienced gynecologist who performed all the procedures, but they were assisted whenever the bowel was opened or resected by 3 general surgeons who were subspecialized in colorectal surgery.
And that multidisciplinary approach is the absolute gold standard for deep infiltrating endometriosis. You have the gynecologist managing the reproductive organs and the ureters, and the colorectal surgeon managing the bowel resection.
The intraoperative details provided in the paper give us a really clear, fascinating picture of how meticulous they were. These were massive surgeries.
The median operative time was 280 minutes.
Almost 5 hours.
Yeah. And during that time, they didn't just focus on the bowel, they systematically evaluated the entire reproductive tract.
Right, they checked fallopian tube patency with dye.
Yeah.
And if they found hydrosalpinges, those fluid-filled, chronically inflamed and blocked fallopian tubes that are just highly toxic to embryos, they were either surgically removed or interrupted.
Which is standard, yeah.
But here is the vital detail I want to pause on.
Yeah.
How did they handle the ovaries? Because the paper notes that ovarian endometriomas were managed exclusively by ablation using plasma energy.
Yes.
Why is that specific modality so important? Why not just cut the cyst out?
The choice of plasma energy ablation is a masterclass in fertility-sparing surgery. When a surgeon encounters a large ovarian endometrioma, the traditional and, frankly, easier approach is a cystectomy, stripping the capsule of the cyst away from the ovary.
Right, just peel it off.
But the biology of an endometrioma means it lacks a true capsule. It is an invagination of the ovarian cortex itself.
Oh, I see.
So when you strip that wall away, you inevitably tear away healthy primordial follicles, which causes a permanent, irreversible drop in the patient's AMH levels.
So cystectomy actively destroys the very ovarian reserve we're trying to protect in these patients.
Precisely. Plasma energy, on the other hand, utilizes argon gas ionized into a plasma cloud. The physics of this energy modality mean that the thermal spread into the surrounding tissue is limited to roughly bottle point 0.2 millimeters.
Well, that is incredibly precise.
It is. The surgeon can vaporize the endometriotic tissue inside the cyst while leaving the underlying healthy ovarian cortex and the precious follicles within it completely intact. When your secondary outcome in a massive bowel resection trial is fertility, utilizing a technology that specifically protects the ovarian reserve is paramount.
That biological mechanism makes perfect sense. You're effectively burning away the disease with millimeter precision without cooking the healthy eggs underneath.
Exactly.
Which brings us to a conceptual pivot in this study that I found completely fascinating. The surgeon in this trial wasn't just like a mechanic removing pathological tissue. The surgeon acted as a real-time, anatomically informed fertility guide.
If we connect this to the bigger picture, this is a profound departure from standard practice. Post-operation, the surgeon sat down with the patient and synthesized everything they had just seen.
Based on what they actually touched and saw.
Right, based on direct tactile visualization of the anatomy, the exact patency of the tubes, the pliability of the fimbriae, the precise volume of healthy ovary remaining. They combine that with the patient's age, their preoperative AMH, and the male partner's semen analysis.
And then what?
Then the surgeon explicitly advised them to pursue either natural conception or art.
I really want to highlight how rare this is. Usually, fertility counseling relies on secondary, indirect indicators. We look at transvaginal ultrasounds, pelvic MRIs, AMH blood draws.
Hysterosalpingograms.
Yeah. It's like trying to assess the structural integrity of a house by looking at satellite imagery and checking the water pressure from the street. You can guess, but you don't really know.
You're blind to the actual state of the rooms.
But here, the surgeon has just spent nearly 5 hours walking through the actual hallways of that house. They've handled the tissues. They know exactly how much healthy, functional ovary is left.
And that direct, anatomically informed advice is incredibly valuable because it removes the guesswork. If the surgeon sees that both tubes are irrevocably damaged despite the bowel resection, they don't waste the patient's time with a recommendation for natural conception. They send them straight to IVF.
And vice versa.
Right. If they see beautiful, patent tubes and a robust ovarian cortex after vaporizing the endometriomas, they can confidently recommend attempting natural conception.
It's personalized medicine based on primary direct evidence. But to truly appreciate the success rates of the surgeon's advice, we need to look closely at who these patients actually were. We need to completely unpack the infertile label that gets applied to them so frequently.
Because the baseline characteristics in Table I of this paper are, frankly, eye-opening. They require a deep dive of their own.
Let's do it.
Out of the 55 patients from the Rouen Center who had prolonged follow-up, 36 of those women explicitly intended to get pregnant after surgery. And the median age of this cohort was 28 years old.
And the follow-up period was massive, right?
Yeah.
Varying from 50 to 79 months with 0 patients lost to follow-up.
0.
From a purely methodological standpoint, maintaining contact with 100% of a surgical cohort for up to 6 years is an astonishing feat for any research team.
It really speaks to the rigorous design of the extended follow-up. But I want to circle back and flag that median age immediately. 28 is young.
Right.
In the world of reproductive endocrinology, a median age of 28 is a highly favorable prognostic indicator for oocyte quality and overall fertility, regardless of the underlying pathology. We have to keep that biological advantage in mind when we interpret the final pregnancy rates.
Absolutely. Youth is on their side. But while their age was highly favorable, their daily reality was absolute agony. The pain profiles documented in Table I are staggering.
It's heartbreaking.
100% of these 36 women experienced dysmenorrhea with a median visual analog scale, or VAS score, of 9 out of 10.
Let me repeat that for context. A 9 out of 10 median pain score during menstruation for the entire cohort.
And 86% had severe dyspareunia, painful intercourse with a median VAS of 5. 83% reported dyschezia or painful defecation.
We are looking at a population where 72% also had chronic intermenstrual pelvic pain, meaning they were hurting even when they weren't bleeding.
Wow.
And perhaps most distressing, almost a quarter of them, 22%, experienced involuntary gas or stool loss.
That is just, it's devastating.
When you digest those functional impairment numbers, you begin to understand the total systemic devastation of colorectal endometriosis. A VAS of 9 out of 10 for dysmenorrhea isn't just a bad period. It means these patients are incapacitated, likely bedridden, and requiring narcotics just to exist.
And this incredible burden of pain leads us to a striking detail from the data. It's something we might call the infertility paradox.
Oh yes, the paradox.
The paper notes that 63% of this cohort,
Right.
so 23 out of the 36 patients, had unsuccessfully attempted to conceive for more than 12 months before the surgery. So by standard medical definitions, they carried the formal diagnosis of infertile.
Right.
But that leaves 37% who were not classified as infertile. Why? Because they simply hadn't tried, or they hadn't accrued a full 12 months of timed intercourse.
Right. They didn't fulfill the strict epidemiological criteria for infertility simply due to a lack of designated time trying.
But I have to push back on how we use that clinical definition, because look at the biological reality we just discussed. 86% of these women had severe dyspareunia.
Yeah.
If a patient has a massive nodule infiltrating her vaginal fornix and her rectum, intercourse isn't just uncomfortable, it is excruciating. So my question is, are many of these women actually biologically infertile, meaning poor egg quality or lack of ovulation? Or are they simply functionally blocked from conceiving due to the blinding pain of intercourse?
You've hit on a massive paradigm shift that the authors themselves explicitly highlight. Severe dyspareunia physically impedes the regular, timed sexual intercourse that is biologically necessary for natural conception.
You literally can't try.
Exactly. The paper notes that for women with deep endometriosis of the rectum, the preoperative likelihood of conception is estimated at less than 13%. If it physically hurts too much to have sex, natural conception is completely taken off the table.
So what happens when these patients go to a standard clinic or a general practitioner? They say, "Doctor, I'm in agony and I want a baby."
This is where we create a massive epidemiological artifact. When a physician sees a patient with this level of advanced disease and a desire for a child, they often look at the old ESHRE guidelines, prioritize speed, and push the patient straight to IVF.
But wait, the moment that patient enters the ART pathway,
She's automatically categorized and recorded in national databases as infertile.
wow, so we are artificially inflating the infertility statistics for DIE patients across the board.
Exactly. We are labeling them as biologically infertile before they've ever had a pain-free, anatomically normal opportunity to try naturally. We are treating a mechanical, pain-based barrier to intercourse as a primary biological failure of the reproductive system.
That is wild.
It heavily skews our understanding of what endometriosis actually does to fertility.
That is a staggering realization. If half the patients in national IVF registries with deep endometriosis are there simply because intercourse is too painful, we are profoundly misunderstanding the disease process.
We really are.
So having established this incredible severity of their disease, the extensive anatomical roadblocks, and the fact that their baseline infertility might actually just be a byproduct of their pain, let's look at what happened when the surgeons at Rouen cleared the roadblocks.
Let's look at the clinical outcomes.
Yeah, the postoperative numbers from that 50 to 79-month follow-up. And this is the data that challenges the entire foundation of the IVF-first approach.
The numbers are incredible.
Here's where it gets really interesting. Remember, we have 36 patients intending to conceive. The headline statistic from Roman et al. Is that 29 out of those 36 patients achieved pregnancy. That is an 81% overall success rate.
I want to pause on that number, 81%, in a population with 20 millimeter nodules actively penetrating the rectal muscularis.
I have to be honest, when I first read that, my initial reaction was pure skepticism. An 81% pregnancy rate in a cohort this sick seems astronomically high. How are they achieving that? Are these mostly IVF pregnancies after the surgery?
That is exactly where the data becomes revolutionary. Let's break those totals down further. Because the follow-up was so long, up to 6 years, several women had more than one pregnancy. They recorded a total of 37 pregnancies across the cohort, resulting in 29 deliveries of healthy babies.
So a 78% live delivery rate.
Right. But the most important number, the number that directly answers your skepticism, is the natural conception rate. Out of the 29 women who got pregnant, 17 conceived entirely naturally. Overall, 65% of the 37 total pregnancies were natural conceptions.
65%. Let that sink in for a moment. 65% of the pregnancies in this severe end-stage DIE cohort occurred without any artificial reproductive technology whatsoever.
Okay.
No stimulation drugs, no retrievals, no petri dishes, just restored anatomy and time.
Yeah.
That fundamentally disrupts the assumption that RT is the mandatory primary pathway for these patients.
It absolutely does. It proves that when you meticulously excise the disease, restore the normal pelvic anatomy, and relieve the dyspareunia, the biological system is highly capable of functioning exactly as it was designed to.
And what about that specific subgroup we talked about earlier? The 23 patients who definitely fit the strict clinical definition of infertile.
Hmm.
The ones who had tried and failed for over 12 months pre-surgery. Did surgery help them?
The results for that subgroup are perhaps the most compelling. Post-surgery, 17 of those 23 previously infertile patients achieved pregnancy.
Wow.
That is a 74% success rate, and remarkably, 39% of those conceptions within the infertile subgroup were completely natural.
So almost 40% of the infertile group got pregnant naturally after surgery.
Yes. It suggests that for a significant portion of these women, the surgery didn't just relieve their pain, it actively restored their fertility by removing the mechanical and inflammatory roadblocks.
So we have a high volume of pregnancies and a high volume of natural conceptions. But a major question for a clinician sitting in a room trying to manage a patient's expectations is the timeline. How long does this take?
Right, time is always the anxiety point.
The paper provides some excellent Kaplan-Meier curves that track the cumulative probability of achieving pregnancy over time. Can you walk us through how we should interpret that statistical data?
The Kaplan-Meier curves and the actuarial life table analysis provide the hard data needed for accurate clinical counseling. According to their analysis, the probability of achieving pregnancy at 12 months post-op was 33.4%.
Which honestly sounds a bit low if you're a patient eager for a baby.
It does. A 33% chance at year 1 might feel discouraging to a patient who just underwent a massive bowel resection. But look at how the curve climbs. At 24 months, the probability jumps to 60.6%.
Okay, that's a big jump.
At 36 months, it reaches 77%. And it peaks at an impressive 86.8% at 48 months.
Nearly 87% at 4 years.
Exactly. When we dissect what these timeframes mean, the message is clear. Physiological healing takes time, and patience is heavily rewarded. It tells the medical professional to prepare their patient for a marathon, not a sprint.
Because the body went through trauma.
Right. Fertility restoration isn't always immediate post-op. The pelvic environment needs time to clear the inflammatory cytokines. The bowel needs time to heal, and normal sexual function needs time to resume.
But knowing that the curve climbs steeply to almost 87% over a 4-year horizon changes the entire conversation. It validates the strategy of waiting, trying naturally, and allowing the body to heal.
It's a message of hope backed by data.
Which brings us to the ultimate debate in modern fertility clinics. The speed debate. If a patient sits across from you, in severe pain but acutely aware of her biological clock, and asks, what is the absolute fastest route to holding a baby in my arms? Standard medical instinct driven by those older ESHRE guidelines says IVF.
Absolutely. You control everything.
Right. You control the menstrual cycle, you control the embryo development, you schedule the transfer. It must be faster, right? But the data from the ENDORE follow-up completely upends that biological assumption.
It is arguably the most surprising, counterintuitive finding in the entire paper.
The statistical outcome actively challenges the status quo. The researchers found that women who were advised by the surgeon to attempt natural conception achieved pregnancy significantly earlier than patients who were referred for ART. The p-value on that difference is 0.008.
Which is highly statistically significant.
And it holds true even when you adjust the starting line. They looked at the data regarding the timeline after stopping the mandatory post-operative medical treatment because many of these women were on amenorrhea-inducing drugs immediately after surgery to allow the bowel anastomosis to heal.
Right. You can't have periods while the bowel is healing.
When they measured the time to conception from the moment they stopped that medication, the p-value was 0.0004. Natural conception was still faster.
And we have to factor in the sheer physical toll of the surgical recovery, too.
Yes. This blew my mind. Out of the 36 patients, 28 of them had a temporary diverting stoma, either an ileostoma, which is a surgically created opening in the small intestine, or a colostoma for a period varying from 3 to 4 months.
It's an intense recovery.
So let's visualize this patient pathway. These women underwent massive, 5-hour radical surgery, lived with a stoma bag on their abdomen for a quarter of a year while continuing suppressive hormonal medical treatment, then underwent a second surgery to reverse the stoma, recovered from that, and still the natural conception cohort got pregnant faster than the IVF cohort.
It is an incredible testament to the resilience of the human reproductive system once the severe pathology is definitively removed.
But let's pause there, because the biological mechanism behind this speed difference is vital. Mechanically and physiologically, why was natural conception faster in this specific study? Because on paper, IVF is designed to bypass the waiting game. I mean, IVF is like taking a helicopter. It seems faster, but requires massive logistical prep, scheduling, and expense. Surgery followed by natural conception is like clearing the traffic jam completely. Once the road is clear, you can just drive straight through whenever you want.
This raises an important question. Why was natural conception actually faster here? We have to strip away the idealized version of IVF and look at the grueling physiological reality. ART is not a magic wand. It is a highly invasive, physically taxing medical process.
Yeah.
It requires weeks of hormonal downregulation, followed by intense stimulation cycles to produce multiple follicles. Then you have the surgical egg retrieval procedure, the laboratory phase of embryo development, and finally scheduling the transfer. And crucially, we must remember that IVF often fails.
Right, it's not a guaranteed baby per cycle.
Exactly. The median number of IVF attempts required to achieve pregnancy in the study was 1, but the range was 1 to 3 cycles. Each failed cycle requires a physical washout period and an emotional recovery period before the patient can endure the hormones again. It stretches the timeline out by months.
So what's happening on the natural side?
Natural conception, on the other hand, post-surgery, can be attempted continuously every single month without clinical intervention, without waiting for the lab to culture embryos, and without waiting for your cycle to align with the clinic's schedule. Now that the dense anatomical barriers are gone, the fallopian tubes are free and patent, and the severe dyspareunia is relieved, the couple has 12 natural chances a year right in their own home.
It's continuous physiological opportunity versus episodic medical intervention.
Precisely. However, and this is big, as medical professionals evaluating literature, we must issue a strong caveat here. We must carefully note the study's own methodological warning. This trial was randomized for the surgical technique, conservative shaving versus radical resection. It was not randomized by conception mode.
That is a massive distinction. The patients didn't draw straws for IVF versus natural conception.
No, they didn't. The patients advised to try naturally were purposefully selected by the surgeon because they had better anatomical findings at the end of the operation.
Okay, that makes sense.
The surgeon vaporized the endometriomas, saw healthy patent tubes, and noted a robust volume of remaining ovarian tissue, so they said, "You have the architecture for this, try naturally."
In the IVF group.
The patients sent to IVF were sent there precisely because they had insurmountable barriers, severe male factor infertility, irrevocably blocked tubes, or extremely low AMH. So when we say natural conception was faster, we are comparing apples to slightly different apples. The natural cohort had a fundamentally better baseline fertility prognosis post-op.
That is a perfect logical transition into our critical appraisal. Before the medical professionals listening start tearing up their clinic protocols, canceling IVF cycles, and booking every deep endometriosis patient for a bowel resection, we need to rigorously stress test this data.
Yes, we do.
We have to ensure a deeply balanced view of what this paper actually proves and what it merely suggests.
The authors, to their immense credit, are very transparent about the statistical and clinical limitations of their work.
Let's run through them. First, the sample size. We're looking at a subset of 36 women intending to get pregnant. Statistically speaking, 36 patients is a very small cohort from which to draw sweeping, global clinical conclusions.
It is. It generates a powerful, paradigm-shifting hypothesis, but it isn't statistically powered to be the final definitive word on global practice.
Second, we have to look at the primary endpoints. The original ENDORE trial was designed and powered to evaluate digestive and urinary function following conservative versus radical surgery. Fertility outcomes, conception modes, and pregnancy delays, these were all secondary observations gathered during the extended follow-up.
Which means the trial wasn't built from the ground up to isolate fertility variables.
Right. Third, we have to keep coming back to the age factor. The median age was 28. That inherently carries a highly favorable fertility prognosis compared to a cohort with a median age of 35 or 38, which is often what you see walking into tertiary fertility clinics.
The paper specifically models this age factor in Table 3 using a Cox's proportional hazards model. They looked at various predictive factors for postoperative fertility. While age under 35 versus over 35 was identified as a factor, in this small sample, the hazard ratio confidence interval was quite wide.
But biologically?
Biologically, we know that operating on a 28-year-old yields different fertility outcomes than operating on a 38-year-old, simply due to oocyte quality.
Naturally. And fourth, the study only looked at massive, deep infiltrations, nodules greater than 20 millimeters involving the muscularis. The authors explicitly state that you cannot automatically extrapolate these incredible fertility results to patients with smaller, less invasive nodules, say less than 2 centimeters.
That's a vital point.
Because for a smaller nodule that isn't drastically distorting the anatomy, a massive radical bowel surgery might actually be an overtreatment that introduces severe life-altering surgical risk without a proportional fertility benefit.
That risk-to-benefit ratio is the razor's edge that every pelvic surgeon walks.
Which brings me to my biggest pushback on the real-world application of this paper. I want to talk about the expert center bias.
Ah, yes.
This trial was conducted by one highly skilled, high-volume gynecological surgeon paired with a dedicated team of specialized colorectal surgeons at a renowned expert center in France. They do this all day, every day. For the average clinician listening right now, working in a standard regional hospital or a smaller surgical clinic, is this reproducible? Can they realistically expect 81% pregnancy rates? Or are they just going to cause massive iatrogenic harm trying to replicate this without the specialized volume?
It is the most vital point of caution in the entire discussion. The definitive answer is proceed with extreme caution. Surgery for deep infiltrating endometriosis of the rectum is not a routine laparoscopic cystectomy. It is one of the most complex, high-risk procedures in benign gynecology. It carries severe, potentially catastrophic risks.
What are the exact numbers on those risks? Because we need to know what we are risking for that 81% pregnancy rate.
Even in the hands of these specific, highly trained experts at Rouen, severe complications occur. Deep pelvic abscesses happen in less than 5% of cases. Rectovaginal fistulas, which are devastating complications where an abnormal connection forms between the lower portion of the large intestine and the vagina, allowing stool to pass into the vagina, occur in about 3% of cases.
3% is not zero.
No. A fistula requires multiple corrective surgeries, massive antibiotics, and extended, miserable use of a stoma bag.
And what does a complication like a deep pelvic abscess do to the patient's fertility?
It can completely destroy it. A major surgical complication introduces a massive cascade of infection and acute inflammation into the pelvis. It can cause dense, frozen adhesions to reform, irreparably damage the delicate fimbriae of the fallopian tubes, and permanently obliterate the pelvic anatomy.
Oh, wow.
The authors emphasize a very specific warning. Complication rates for surgeons with low-volume activity surgeons who don't perform deep bowel resections every single week will undoubtedly be higher. Attempting a 15-centimeter low rectal resection without multidisciplinary colorectal support might achieve the exact opposite of preserving fertility.
So the technical skill and case volume of the surgeon is literally a predictive factor in the biological fertility outcome.
Absolutely. The paper mentions another study by Bendefala et al. That explicitly links hospital and surgeon case volume to morbidity in colorectal endometriosis management. High-volume centers have lower morbidity. It's a direct correlation.
Okay, so navigating this incredibly complex landscape, balancing the astonishing 81% success rates against the strict methodological limitations and the severe life-altering surgical risks. What is the final takeaway? Moving from the raw data and our critical appraisal into actionable, clinic-ready advice.
Yeah.
So what does this all mean for the medical professionals listening right now as they prepare for tomorrow morning's patient consultations?
First and foremost, it means the rigid dogma of the 2014 ESHRE guidelines needs a massive asterisk. The paradigm has shifted. First line, expert-level surgery is a valid, evidence-based, and highly effective option for young patients with large colorectal DIE and a profound desire for pregnancy. It is no longer considered experimental or unproven to offer surgery before IVF.
It aggressively validates the dual benefit approach. For a young patient sitting in your office in agony, you no longer have to force her to choose between treating her debilitating pain and achieving her dream of a child.
Exactly.
Expert-level surgery treats the root cause of the agonizing pain, drastically improving her gastrointestinal function, eliminating her dyspareunia, and restoring her quality of life, while simultaneously offering an 81% chance of achieving pregnancy, predominantly naturally.
And this is a critical non-negotiable, but offering this pathway requires intense, individualized, and brutally honest preoperative counseling regarding the risk of ovarian reserve impairment. You cannot promise a patient that her ovaries will emerge completely unscathed from a radical pelvic clearance.
Yes, let's talk about the specific, terrifying anecdote the authors deliberately included in the results section, because it is an absolute nightmare scenario for any fertility specialist or surgeon.
They detail the case of a 30-year-old nulliparous woman, meaning she had never given birth. Preoperatively, she had no ovarian endometriomas whatsoever. Consequently, the surgeons performed absolutely no surgical procedures on her ovaries during the bowel resection. They didn't touch them with instruments, they didn't use plasma energy, nothing.
Okay.
Yet, Post-surgery, her AMH level unexpectedly and catastrophically plummeted from a very robust, healthy 3.5 nanograms per milliliter down to a menopausal zero point 0.3.
From 3.5 to zero point 0.3, that is a total collapse of her ovarian reserve at age 30. And they didn't even operate on the ovaries. How does that biological mechanism even work? How do you destroy the reserve without touching the tissue?
It comes down to the microscopic vascularization of the pelvis. It's like trying to prune a massive, overgrown, deeply rooted vine off the side of a house. Even if you are meticulously careful to never touch the delicate flower boxes sitting on the windowsills, the ovaries. If, during the process of hacking away the dense vines from the brickwork, you accidentally sever or compress the main irrigation pipe buried beneath the vines, the flowers in those boxes are going to wither and die from ischemia.
Because the blood supply is compromised.
Exactly. The vascular web of the female pelvis is highly complex and intimately interconnected. When you are resecting large fibrotic portions of the rectum, the posterior vagina, and the uterosacral ligaments, and remember, 83% of these patients required resection of the posterior vagina, you are dissecting millimeters away from the uterine and ovarian arteries.
Right.
Even without direct thermal or mechanical trauma to the ovary itself, altering the surrounding pelvic vasculature or causing surrounding tissue inflammation can severely compromise ovarian blood flow, leading to ischemic necrosis of the primordial follicles and a permanent, devastating drop in AMH.
That is a chilling reality for a surgeon. And it highlights exactly why the physician must offer a deeply nuanced, balanced perspective during the initial consultation. You cannot operate as a salesman for surgery.
Never.
You have to lay out the potential benefits, an 81% chance of pregnancy, the restoration of natural conception, massive life-altering pain relief against the severe potential harms, like a 3% chance of a vaginal fistula or an unpredictable, catastrophic ischemic drop in AMH.
Which redefines the surgeon's role entirely. Under this new paradigm, they are no longer just procedural mechanics removing pathological tissue, they are fertility strategists.
I love that term.
The intraoperative assessment they make while looking through that laparoscope, evaluating the pliability of the tubes, the collateral damage to the vasculature, the quality of the ovarian cortex, is the single most accurate prognostic indicator for guiding the patient's next steps. Their post-operative advice on whether to attempt natural conception or immediately pivot to RT becomes the definitive compass for the patient's entire reproductive future.
It is a staggering amount of responsibility to hold in the operating room. And as we look to the horizon to see where the field of gynecological surgery and reproductive endocrinology is heading based on this foundational text, we have to ask, what is the next logical step in the research? How do we prove this beyond a shadow of a doubt?
Both the authors of this paper and the broader reproductive medical community agree on the exact requirement. While the ENDORE follow-up is highly encouraging, validates the surgical pathway, and completely shifts the clinical paradigm, it is ultimately an observational outcome of a surgically randomized trial.
Right. It wasn't powered for fertility.
Exactly. The absolute gold standard that the field desperately needs is a true head-to-head randomized controlled trial comparing primary expert surgery directly against first-line IVF for fertility outcomes in patients with severe DIE.
And the incredible news for the field is that this paper actually points toward that exact future. They mention the ongoing ENDOFERT trial in France. ENDOFERT is designed specifically to answer this burning question. It is randomizing patients with colorectal deep infiltrating endometriosis to either complete primary surgical clearance or first-line IVF, with the primary endpoint being the cumulative live birth rate.
When the data from the ENDOFERT trial is finally published, it will undoubtedly become the definitive global guideline for the next decade of endometriosis management. But until we have that data, H.Roman and his team have given us the strongest, most compelling evidence yet that the surgical pathway is not just viable, but potentially biologically superior for the right patient in the right expert hands.
It's a study that truly respects both the devastating complexity of the disease and the incredible resilience of the female anatomy. Thank you to everyone listening for joining us on this incredibly dense deep dive. We know your time as clinicians is incredibly valuable, and we hope this granular physiological look at the data serves you in your next difficult patient consultation.
It's always a profound privilege to unpack this level of advanced clinical science with you.
Before we sign off, I want to leave you with a final, slightly provocative thought to mull over. We've spent the last hour dissecting how expertly clearing the massive fibrotic anatomical roadblocks of endometriosis can lead to a 65% natural conception rate in a population previously labeled by national databases as functionally infertile. If meticulous surgical excision of deep endometriosis can restore natural fertility so effectively, we have to ask ourselves a difficult philosophical question regarding our modern medical instincts. Are we over-medicalizing human reproduction with early, aggressive, and highly lucrative IVF interventions simply because we've been too hesitant or perhaps undertrained to advance and utilize our surgical techniques? As you head into your clinic tomorrow morning, look past the initial symptom of infertility, look past the easy road of the petri dish, and consider whether the absolute best, most lasting fertility treatment for your patient might just be doing the incredibly hard, meticulous work of restoring the body's original anatomy. Until next time.